planovalgus foot. I will focus only on the planovalgus foot. Like this is where, when we see such child, we need to decide a few points. The first, it's a three-dimensional deformity involving three joints. The effect of the extent of deformity, how severe is the planovalgus foot, we need to see when the child is weight-bearing. Then there are two muscles, the gastroc and the peronei. They are probably causing the deformity, and they may be short when there is a planovalgus deformity. So we relax the gastrosoleus in a non-weight-bearing position by plantar flexing the ankle, and we see how much correction is possible. Peronei are usually short, but there is no clinical test by which we can decide the role of peronei in planovalgus foot. The one important thing which I would like to mention, that whenever we try to decide to operate such children, we need to see that is there a supination deformity of a forefoot? I will try to explain this point. As if you are looking from the foot behind, right? The hind foot is in a neutral alignment. The forefoot, the five toes, they are also in a neutral position. Now there is a valgus foot. Hind foot is valgus. So initially the first metatarsal will touch, but the fifth will not touch. That will result into the compensation in which the forefoot rotates or the supinate. So that's a forefoot supination. With time, that becomes fixed. So now when we carry out a surgery and when we achieve a neutral alignment of the hind foot, that results into the supination deformity of the forefoot. And if we don't realize that, then this would result into the child walking after surgery with the first metatarsal elevated. So we need to make sure this at the time of surgery. Now coming to the last point, the musculoskeletal impairment, the bone problems. There are two type of problem. Either the femur torsion is a problem, usually we see a femoral anteversion, and the tibia is externally rotated. These are the two problems. Now how we carry out a femoral torsion alignment? When the neck is horizontal, the femoral torsion is decided by the axis of a neck and the distal condyle. When neck is horizontal, the greater trochanter is most prominent. So the femoral torsion is a axis or an angle between the neck and the line passing through the two condyles. So to have an idea about the line which is passing through the distal condyle, we use as a leg as a reference line. So for the assessment, this can be carried out in a supine or in a prone position. We flex the knee joint, rotate the hip till the greater trochanter is prominent, and measure the angle which legs make with vertical line. So this is how we carry out this assessment. We rotate the hip. When the greater trochanter is most prominent, at that point, we measure the angle legs make with a vertical line. Again, the tibial torsion is decided by a bimalleolar axis, a thigh foot angle, or a second toe test. I will explain the one which is very commonly done, bimalleolar test, in which the proximal reference line is a line passing through the femoral condyle, and the distal reference line is the line joining the two malleoli. This is a proximal line, the distal line, and the angle formed by the two is a bimalleolar axis. That gives us idea about the femoral torsion. So we have seen that there are short muscles, we saw hamstring and calf evaluation. In the long muscles, we saw quadriceps. In the joint problem, we saw how to carry out foot assessment. And the bony torsion, we saw both femur and tibia assessment. I would just skip this part because it's already in the handout. Let's revise what we learned. The first is, how many musculoskeletal impairment? Good. How many neurologic impairments? How many? 1, 2, 3, 4, 5, 6? Fine, there are 5 neurological impairment and we have a very little control on that. The assessment should evaluate how many impairments? Fine, it's my test. It should evaluate all. The management principle based on this assessment, I will try to cover in my next talk, which is soon after the lunch. Thank you.
Great. Can you hear me okay? Good. So we've had two excellent talks this morning, and now can we leave the lights like this? You guys are all right? You can see the screen. It's nice for me to see whether any of you are drifting off, because I can then direct questions accordingly. Don't feel scared. I'll prompt you with the answers. So my job here is to talk a little bit about the ambulatory kids with cerebral palsy, and to introduce to you some of the terms that we use to describe how they walk, and what some of the concepts in understanding what we do about them. The closest analogy I could find to this is very close to our hearts in India, and it is the concept of fielding positions in cricket. And for those of you who aren't familiar with cricket, you will understand that the language that people use is sometimes extremely curious. So the terminology that we use in GATE also uses phrases and expressions that we'll try to understand this morning. A lot of what I talk about is because of these two people I work with, Professor Graham and Paolo Selber, and you've seen Dr. Uni point out one of the pictures that they produced in one of their earlier publications. I also work in the GATE lab at the Children's Hospital, and we've got a large team of people, and these are not all doctors. Some of them are doctors, i.e. PhDs, others are physios, there are engineers, and there are people who help out with research projects and so on. So there's a lot of very clever people helping me understand what there is to know about children walking with gait abnormalities. So with that understanding that I developed, the concepts that I'd like to talk to you about this morning are a language to describe the gait, so that when you actually observe the child walking, you can kind of put things in a frame of reference, and that will register with you the problems that you will then be able to expand on further when you measure how they are walking, when you measure what you find during the physical examination. And then, at the end of it all, to try and work out what does that mean. I mean, it doesn't matter at all if a measurement is done, but if it has no kind of relevance, it will be useless. So the things to worry about here are whether what you observe is normal, whether it is pathological, and very importantly in children, whether it is a compensatory mechanism, because kids are very clever. They are born with this problem that they can't get rid of, but they're very clever at trying to work out what they're going to do to try and overcome it. So we'll have a look at a few of those things as well. In the course of a child's development, one of the things we also talked about earlier is that their gait is not the same later on as it is when they are younger. And we all remember that we have an 18-month kind of limit to say most children should start walking by the age of 18 months. And if they haven't started walking by that age, then there may be something wrong. But even if they start walking, the way children walk when they're toddlers is very different to the way they walk when they're about 5 or 6 years old. And we saw in those development curves that things improve as they go along. So these motor milestones are also important for us to register, that a child will start walking in a pattern that is similar to an adult pattern by the age of 5 or 6 or 7, depending on how closely you measure it. The pattern of walking, therefore, is a determinant of how mature that gait is. So if we talk about interference or any kind of management thing that we introduced before that, it has to take this into consideration. So when you think of how children walk normally, you have to think of 4 things that contribute to that, and these are the 4 things that we will look at very quickly. Of course, we know now, and we've talked about it this morning, that the control system is where you have the primary problem in cerebral palsy. And that primary problem can affect any of these first 3 levels, not so much the lower motor neuron level in cerebral palsy. But this control system is responsible for the initiation and control of movement. And it is also responsible for the balance and stability throughout activity. The next concept that you must keep in mind is how efficient is it? Is it efficient to walk in a particular way? And what determines that? Is it the amount of fuel and oxygen that can get to the muscles? How is it converted into energy? And what does that mean in terms of how fast the child can walk and how far they can walk? So these are things that we can also measure during their gait. The concept that Dheer and Bhai talked about very nicely is the fact that when you look at musculoskeletal movement, you're talking mainly of a very elegant mechanical concept called a lever. Now, in gait, all these limb segments act as levers, and the movements that occur around specific joint axes. And you will know very well that if you have a joint axis that has been malaligned for any reason at all, it will not work as well as it would if it were normal. So this assessment of what is an abnormality is one of the big problems in cerebral palsy that we need to find out. The next is that these skeletal levers work to convert the power that the muscles generate and to move the limb segments in a particular way. The concept that we add to this is what's called the ground reaction force, and this is the force that is projected from the ground back up to the limb, and there is a very important kind of mechanism or concept that involves that. The second is that these levers make it easier to achieve movement because of the mechanical advantage that they impart. Now, when we measure this, we use a concept called an angular acceleration, which is a mechanical way of thinking about this that helps us understand it better, but that's not something we will go into today. So the muscles themselves, it's quite easy to understand that they will generate this force, but it's also important to understand that if they are abnormal, then that difference between normal and abnormal will affect the function of the muscle, the form of the muscle, and the amount of power that it can generate. So, to repeat this as a basic concept to keep in our mind, normal walking requires normal neurological control. It requires the availability of energy, both with glucose and oxygen. It requires the skeletal levers to work in an efficient way and muscles to power that effectively as well. So what's the aim of all of this? The aim of all of this is to get this. The more efficient we are, the further we can walk, the faster we can walk. And in that way, we will be able to get from point A to point B in the fastest way possible. That's what everyone's aiming for. So how do we measure this? This is where we start getting into another concept. There are two ways in which this was looked at over the last few years, and we'll very briefly look at it. The first concept was talked about by Vern Inman in the 50s and 60s when he started looking at how gait could be measured, and the second concept was described by Jim Gage. Vern Inman called them the determinants of gait, and Jim Gage called it the prerequisites of gait, and we'll have a look very quickly at what that means. The determinants of gait are looking at different aspects of the lower limb, the pelvis, what the knee does, the interaction between those components, and whether there are any malalignments at the hip, at the knee or the hip. But what they want to do, all these things, is they want to keep the center of mass steady. And we all know that if you have a wobbly